Good evening, everyone. Today I'm being joined by Dr. Elias Tsakos from Embryo Clinic in Greece. He will be joining me in just a second. And the topics that we are going to be covering today are around the implication of the pandemic for your fertility journey. Here he is. Hello. Let me join you now. Just hello to everyone who's joining. Just bear with us whilst it's connecting.
Hello.
Hello, how are you?
I'm very well, thank you. How are you?
Good. Yes, very well, thank you. Hopefully the internet connection will be good for us.
Sure.
Thank you for joining us this evening. And people are joining as we speak. So hello to everyone who's joining. Hi, Jana. So I'd love you just to introduce yourself, please, and tell us a bit more about your role and what Embryo Clinic does and offers. And then we can start to cover some of the topics that are obviously on people's minds.
Sure. Thank you so much for the invitation and for organizing this event. My name is Elias Tsakos. I'm a fertility gynecologist. I'm UK trained and certified. And I do work as a medical director of Embryo Clinic in Greece, but also offer consultations in the UK, Cyprus, and all over the world. So I would be delighted to share with you my experience with regards to the COVID pandemic.
Wonderful. Thank you. And also everyone who's joining, please feel free to interject with questions as and when you want anything answered. Obviously, you've got a huge amount of knowledge, which it would be wonderful if you could share with us this evening. So why don't we start a little bit about just talking about the general implication of the epidemic on people's fertility journeys and IVF and fertility treatment as a whole?
Sure. I mean, number one implication is the fact that most of the IVF units in the Western world have been shut down in the period of the last 6 weeks or so. We in Europe have been the first ones to have been shut down by the regulation of the European Society of Human Reproduction. But across the Atlantic, most of the the US fertility units have been closed down as well. And of course, all of the UK clinics and most of the clinics in Europe. I understand that today there's been an announcement in Denmark, and I think Denmark and Danish units are going to be the first ones to reopen next week.
Oh, really? Next week? Wow, gosh. Because I believe, and please someone correct me if I'm wrong, but the UK may be continuing to be in lockdown for a further 3 weeks. So it would be interesting to understand a bit more about clinics in other countries and the protocol and what might be happening in terms of opening the doors again.
Sure. There's been a huge impact. I mean, we've been, of course, absolutely devastated for our patients. Our patients have had to discontinue their journeys. We had to wrap up the treatments, do the egg collections, the embryo transfers, and just close the units as soon as we could. All that in continental Europe happened in the last 20 days or so. So the impact has been amazing, and this is something totally unprecedented, of course. Having said that, in Greece, as you probably know, the epidemic has been quite soft. We've been quite fortunate. The measures have been taken quite swiftly, and we have suffered very, very small effect. We've only had just over 2,000 cases of COVID, right, and just over 100 deaths, which has been absolutely amazing. So Greece hopefully is going to be one of the first countries to reopen, both socially and business-wise. We're hoping in the next 10 days or so. Right. And also the IVF clinics we're hoping to reopen in the next fortnight.
Okay. And when you're able to open the doors again, how are you planning to manage the protocols and manage the patients in terms of order?
Sure. We're expecting to hear from the official societies and from the official ministries and avenues. Having said that, of course, we're in talks with our European, UK, and American colleagues, and it seems that there should be quite a few differences in view of the COVID epidemic, which is slowing down, but it's not disappearing altogether. So I think a couple of important issues here would be prioritizing treatment. Of course, a lot of patients have been cancelled, so these patients will have absolute priority in being treated in the next few weeks. Secondly, we will prioritize the the urgent cases, for example, women approaching the age limits.
Right.
And also women, of course, who do have some sort of urgency for their treatment. I mean, cancer patients undergoing fertility preservations have always been top of our list. But of course, ladies with low AMHs or ladies very near the age limit of either own egg IVF, which currently is age 45 in Europe, or egg donation, which is currently at 50.
Mm-hmm. Because actually that's one of the concerns that a lot of our readers have been voicing, the fact, especially in this community, the fact that people feel that obviously this uncertainty of not knowing when treatments can continue or start panics people, because they're worrying about their AMH levels lowering and the fact that they're not getting any younger whilst this is going on. So it's really difficult, obviously, as you understand.
Sure, it's devastating for us. I mean, we feel very embarrassed to having to cancel patients, especially my team and I. We've been working endlessly ever since the shutdown, trying to support our patients. We've been on the phone for endless hours during the day, trying to come to terms ourselves first, and then, of course, try to consult our patients as to how to prepare best for the next day. There's a lot of things that could be done in the meantime, of course, in preparing for the next day. We need a lot of support to be given to our patients, both physical, emotional, and spiritual. And we reassure everyone that the next day is around the corner. It's going to happen very soon. And please don't be devastated. It's only a matter of a few weeks now.
That's really positive news to hear, really positive. And obviously it gives people hope and something to look forward to, if you like.
Sure.
And
If I may, I mean, I have another piece of positive news, which is that at the moment there's no, in terms of pregnancy, although there are reports now, up until 2 days ago, I mean, we've been updating our evidence daily. Up until 2 days ago, there was no evidence of transmission of the virus to the fetus and the newborn. Sadly, there's been a couple of cases in the world in the last 24 hours, 48 hours, that there is some cases that the virus has been transmitted to the baby in pregnancy. However, good news is that there's no maternal deaths so far because of the virus, and also the fact that until now the evidence is that the severity of the illness in pregnant ladies is not as is not bigger than non-pregnant ones. So with regards to pregnancy effect, it seems to be quite soft at the moment. Now, with regards to fertility and genetics, the brilliant news is that until now, the evidence is that the virus is not attacking the reproductive organs, is not attacking the reproductive cells, the eggs or the sperm. So we're quite optimistic from that point of view.
Okay, that's really good to hear. And you just mentioned that there have been some cases of the virus transmitting through to the fetus. Have the babies been okay? Do we know that yet?
Well, the outcome of the babies depends on the overall outcome that they would have had anyway in terms of prematurity and other confounding factors. But the other piece of good news is that breastfeeding is allowed. So nothing will stop pregnant women breastfeeding their babies, even if they're positive for the virus. Of course, they would have to take precautions for that.
Yeah. Someone's just said, this is so lovely to hear. I completely agree. This is some good news when everything has just been so scary and overwhelming. And just to go back to your the conversation we were just having about things reopening again. Do you think, or do you know yet whether you'll be able to open all kinds of fertility treatments at the same time? So, for example, will people be able to have start a new protocol with egg retrieval, stimulation, etc., as well as having frozen embryo transfers, as well as IUI, for example? Sure.
Absolutely, yes, is the answer. So all the fertility treatments, well, at least on the continent and definitely in Greece. I mean, Greece seems to be one of the first countries planning to reopen, in view of the fact that we have been over the curve and our curve has been very, very soft and very, very low. So yes, all the treatments should be available. Of course, there's this question as to whether people should be able to travel, especially international travel is not going to be allowed for another 4 to 6 weeks. However, there's a lot of discussions as to the conditions that will allow international patients to visit us.
So how does that work? For example, if your clinic opens in 10 days to a fortnight, and people in the UK potentially watching now are interested in coming to Greece to see you at Embryo Clinic, could they start the process now virtually without knowing when they might be able to actually start a cycle?
Sure, absolutely. I mean, as you know only too well, the minute we start talking about a possible cycle, we need at least 4 to 6 weeks before we initiate that cycle. So, by all means, yes. I mean, we are taking inquiries, and we're prioritizing our patients. I mean, we're already booking cycles for the 20th of May and further down the line. So absolutely is the answer. So if anyone is interested, they could start inquiring, and then of course we can streamline all the tests and all the evidence we need before we embark on a cycle. Another piece of good news is that although traditionally in Greece most of the units, including ours, we've been closing for most of August, because of this urgent situation, we should be able to remain open and cater for our patients during that time.
Brilliant, brilliant. And if people were interested in starting virtual conversations and then potentially booking in for a cycle, let's say in June or July or in the autumn, not knowing whether travel bans will be lifted, is that flexible? Can people transfer it to a later date if they're not able to travel?
Absolutely, absolutely is the answer. I mean, the sooner people start discussing and start preparing for the next cycle, the better. And that's both and psychologically. And that would allow us to make appropriate plans and ensure, of course, safety and quality for the treatment.
Absolutely. Yeah, 100%. Does anyone have any questions at this point? You've given us some really great positive news. If anyone's just joined, just to recap, we've just been discussing about the fact that there doesn't seem to be any data to show that people who've had the virus, correct me if I'm wrong here, have had any sort of issues with egg or sperm quality as a result of having the virus. And also clinics may be starting to reopen, potentially in Greece, in the next 10 to 14 days, which is really exciting. Greece is actually a country which hasn't been as badly affected as other areas of the world. And then we've just been talking a bit about what will happen when the doors reopen and how patients might be prioritized, and I guess how you'll handle the number of inquiries and the number of people wanting to start straight away. I'm so sorry, someone did ask a question, Style Cartel. What did you ask? I think you asked, is 52 late to have the baby? Did you hear that one?
Sorry, I didn't hear you.
Oh, sorry, the connection's not great. Is 50 too late to have a baby? Someone has just asked.
Well, it depends on who is answering. If I'm answering, the answer is no. Sadly, the legal people have answered in Europe and in Greece that it's probably a little bit late. However, there's a huge trend at the moment to push the boundaries, the age boundaries in Greece to 53. We were hoping to have this legal arrangement over and done with basically in spring of this year, but this has been postponed. So my advice for that lady would be to not to give up, to start preparing, to keep healthy, and hopefully when the regulation in Greece changes, we should be able to treat you. We're hoping to hear about this in the next couple of months.
Okay, and is that would that normally be with donor eggs, or could that be possible with your own genetic eggs?
Well, absolutely donor eggs.
Yeah, yeah. Okay. Does anyone else have any questions at this point? In Spain, it's okay. Thank you very much. Okay. Supplements to improve egg quality.
Well, long discussion. I mean, we could spend hours for that. I mean, in general, nutrition is very important for egg quality and for general health. I would personally start with nutrition before I moved on to supplements, because supplements, no matter how natural they claim to be, they're not 100% natural. So I I would prefer nutrition, understanding about nutrition, working with a nutritionist perhaps, or fertility dietitian in order to improve habits, to improve diet, nutrition, and so forth. Get the weight sorted, get the exercise and stress level sorted, and so forth. So I would move on to supplements when I've exhausted all the natural options, because no matter how much they claim, supplements are not always natural.
Yeah. Yeah, but a healthy well-being is something that people can put into practice now, isn't it? This downtime is a great time to get prepared.
Absolutely, this is the perfect time to come to terms with the fact that the better prepared they are, the better success they will have. And success, I mean, the way we define success at Embryo Clinic is not just getting pregnant. We define success as a successful experience, as an experience in which there's no risks. An experience in which everything is as pleasant as possible, as positive as possible. Even the negatives can become positives when someone is well prepared and well looked after by a caring team. So absolutely, this is the best time to prepare for that.
Good. I guess that's one positive way to look at this time, isn't it? Whilst we're in limbo waiting. We've talked a bit about fertility protocol, and we were going to talk a bit about success rates.
Mm-hmm.
Sorry, over to you.
Yeah, I always start by saying it's statistics, dumb lies and statistics, or something like that. I mean, it's very difficult to quote success rates. There's no agreement between us. I mean, I need to apologize as a doctor of almost 30 years experience that there's no transparent way to explain or to convey what success is. Depends on the definition of success. My team and I would define success as successful experience. I mean, you can have someone pregnant who has had a terrible experience, who's been under a lot of risks, a lot of threats, a lot of complications, and so forth. With regards to the absolute success rate that most people are looking out for, again, please watch out. I mean, anyone can quote success in a different way. I mean, for example, if in my clinic, if I reject anyone with an AMH of less than 4 picomoles per liter, then of course I can have better success rates for the particular age group. Or if I'm just pulling embryos and I'm doing one embryo transfer with the best blastocysts that I can find over a 2-year period, I can still have a better success rate for the 42-year-olds compared to anyone else. So all I want to say is that as a patient, as a couple, no matter how experienced you are, and most of our couples, thankfully, are very well read, very experienced. They've been around, they've met a lot of doctors, they've had a lot of IVFs, some of them successful, some of them not. I mean, most of our couples are very well informed, and we're learning a lot from them. In my experience, I think there's a lot of surrogate markers by which you can tease out what the success for you would be in a particular clinic, and I can be more specific. For example, ask the clinic very simple questions. Are you working 7 days a week? Are you doing egg collections, embryo transfers 7 days a week? Are you, what kind of seniority of doctors are doing the treatment? I mean, there are some amazing clinics with some absolute legendary doctors and professors who actually are never doing the treatment themselves, and so forth. So I think it's very important. Even within our clinic, we have our own audits, and we have different results depending on who is doing the embryo transfer, the egg collection, and so forth. So that's another factor as well. Number 3 factor to look at is, again, of course, the seniority of the embryology staff. I mean, in my time when I was training with amazing people in Bristol in the early 90s, or in the northeast of England, or in the southeast of England, in Norwich, in the mid-90s. I mean, embryologists were legendary, and they were just highly qualified people, and so forth. Embryology now has become a more technical aspect. I mean, you can have a technician doing ICSI, and they could be very good in that, but they may not be fully trained embryologists and all that. So unless you meet the clinic, and unless you visit it, unless you've spoken to the doctors, to the embryologists, to the nurses, to the coordinators, to the cleaners. I mean, we are very grateful to our cleaners, to our ladies who are looking after our hygiene at the moment for not contracting any virus, or none of our staff has contracted, or patients any virus and all that. So I think it's a whole package, and this is the only way that someone can really access success.
Fantastic advice. I think for me personally, when I was going through IVF, having that personal touch really helped. To be, sorry, my battery there. You want to be feeling like a person rather than a number, as it's such, obviously, as you know from your patients and doing it for so many years, such an emotional thing to be going through. You need that support. And in terms of people contemplating having treatment abroad, potentially in Greece, are there things that they can be doing in normal times, you know, from home, say in the UK, in America, wherever they're coming from? Are there tests, etc., that they can do from home before coming out to you, so that they're not in Greece for a really prolonged period of time when they might be worried about work schedules, for example?
Sure, absolutely. I mean, there's a lot of tests, a lot of preparation work that needs to be done and has to be done in the UK. I mean, through our contacts all over the UK, we have streamlined our process. So we aim to do as much as we can locally for our patients. So we do have associates and collaborators all over the country, all over, you know, England, Wales, you know, even Ireland and Scotland. So yes, we would like to streamline that. We would like to get as much information as possible before we even embark on taking somebody on, because it's quite important to explore together the options. And there's always a lot of options. I mean, I'm quite confident in saying that anyone can get pregnant. The question is, which is the best way for them? And how far are they prepared to take this journey? So, for example, you know, somebody in their late 30s, they can get pregnant, of course, with their own eggs. Somebody in their early 40s, they can still get pregnant with their own eggs. If they fail, they move on to egg donation. With egg donation, I think if anyone has a reasonable partner, male partner, or even no male partner, in which case we use a sperm from a sperm bank, could expect a reasonable uterus with no particular anomaly, but even with small anomalies, they can have a cumulative success rate of very near 90% with egg donation, even in the early, mid to late 40s. With egg donation and sometimes sperm donation, it's highly unlikely that somebody will not get pregnant, as long as they're prepared to take the journey. And I can always quote dozens of our patients who persevered and they managed to have 1, 2 or more babies. Even if that fails, which is highly unlikely to fail, there is still surrogacy. There's still gestational surrogacy. Yeah. So if somebody is really prepared to go all the way down the journey, and if somebody is understanding of the limitations of science, and the limitations of human biology, and if they're prepared to pay the price, emotional, physical, financial, social sometimes, then they can always become parents. And these are double parents compared to us, or treble parents, because they've been working very hard for something that for some of us has been just a natural selection.
Absolutely. And it's not just getting pregnant, is it? It's obviously sustaining the pregnancy and having a healthy child at the end of it as well.
Yes, thankfully, I mean, there's been a lot. I mean, obstetrics and antenatal care has been amazing over the last 10, 20 years. I mean, 10 years ago, it was totally unheard of that we would be able to find out the DNA of the baby by doing a blood test on the mother. And now this is commonplace. So equally with the coronavirus, if I want to go back to our main subject, I mean, it normally takes about 10 to 15 years, maybe longer, to develop some sort of prevention inoculation. And now we're hoping, and we're almost confident, the International Scientific Society, that an effective inoculation should be available in the next maybe year and a half maximum. So I think our generation has been quite lucky and quite fortunate. We as doctors to be able to provide our patients with the best care, and of course the patients, because there's a lot of options, and there's a lot of safety features that could come along with the options.
Absolutely. Yeah, really, really wise advice. Thank you. Does anyone have any questions at this point? I can see some people have joined. There is actually a question that I was sent previously that I wanted to ask on behalf of someone, because I'm not sure whether they've managed to join yet. They have had one or a couple of unsuccessful IVF cycles, and they've got one blastocyst remaining. Would you generally advise someone to have that blastocyst transfer before starting a new cycle again?
Absolutely is the answer. Absolutely. A blastocyst is a very, very precious embryo. So in my opinion, I think that should be utilized from the biology, from the genetics, from the ethics point of view. In my view, in my mind, if it's a good quality blastocyst, then I would expect it to be a good quality, otherwise it wouldn't have been cryopreserved. Please go ahead and use it. Having said that, there's a lot of preparation you can do on yourself, the female partner, of course, before accepting that blastocyst. So, make sure that the environment, the physical and the emotional environment is the right one. And of course, that the time is the right one to have this embryo transfer.
Really great advice, thank you. Bird in the North asked a question. Is it possible to answer? Sorry, would you mind repeating the question, please? I'm not sure what was asked at that point. And if anyone else has any more questions, please do feel free to ask away. I know someone just said they really want to get pregnant, and obviously we've just been discussing some different treatment plans, protocols, and hopefully the fact that things will be normalizing soon-ish. Everyone is obviously desperate for that to happen. It's the worst feeling for someone who's desperate to start a family, to have to put this on hold with that uncertainty. So my heart goes out to everyone. And I know, as you said, managing your patients, managing their expectations, and the sadness and despair they're feeling, you're obviously feeling it through them too. Sure. So thank you so much for your time this evening.
You're very welcome.
I don't think that any more questions have come in, but if you do have any more, please feel free to send them over, and I will pass them on. And I'll also be putting this up in my stories so that people can watch it back. Sorry, last question. What are your thoughts on taking DHEA?
Generally positive thoughts, as long as we define the successful outcome. I mean, we don't expect miracles. DHEA at the moment is backed up by quite a lot of evidence that for a proportion of patients may be helpful. It may have some small side effects due to its androgenic activity. However, priming with DHEA, especially poor responders or women of what we call an advanced reproductive age, may give us a little bit of an edge with regards to the possibility of having a more effective ovarian stimulation.
Okay. Good, thank you. Did you ever have success with embryos developing on day 7 at grade 4 CBE?
I'm afraid not, is the answer.
Okay. Would you mind just explaining very quickly a bit more about grades?
Yeah, I mean, it's very simple. Grades is something subjective. So, for example, like everything in life, what someone is beautiful for someone, it may not be beautiful for someone else. Of course, we do have criteria. Our embryologists, they have this ability to grade embryos. Now there's even artificial intelligence involved into this. In general, there is an agreement as to what is grade A or grade B. There isn't a huge agreement as to what is grade A plus or A minus or B plus and B minus. Perhaps it doesn't matter so much. But with regards to blastocysts, for example, in my view, and I'm not an embryologist, but as a clinician, I would not rely on any blastocyst on day 7. So for me, this is more important than the grade itself. Sometimes, yes, we do see blastocysts on day 6. Lunchtime on day 6 for us is the cutoff point. Beyond that, it's very unlikely to have a good quality blastocyst, which would have a good chance of pregnancy. Having said that, there's other methods to assess the quality, and we're talking always about the external appearance of the embryo. So we can use the time lapse or the embryoscope. There's been a lot of research about that. there is a little bit of evidence that it may help. And of course, if we want to move on to something a little bit more sophisticated, then of course we have the PGS, the PGTA, whatever the terminology, doesn't matter. We can do genetic screening on the embryo because, as we probably all know, after the age of 35 plus, a good proportion of the embryos are genetically abnormal, and perhaps this is one of the reasons why IVF fails. However, even this is a little bit controversial. It's becoming a little bit more clear. It has become clear in the last few years, simply because we have the second generation PGS or PGTA, and also because of the fact that we're now testing blastocysts as opposed to day 3 embryos. So this is a very short summary. So it's a very long discussion, in my opinion. The couples, the patients, they need to be involved in that discussion, which has to be very frank, very sincere. We have to admit the areas that we don't know very much about. For example, when we assess morphologically an embryo, we have to accept that at least 1 in 3 or 1 in 2 sometimes embryos would be genetically abnormal anyway. In my opinion, I think we should only be focusing on top quality embryos. And we should be very strict in what is top quality at any stage of development. And that equally applies on fresh embryo transfers, but even more so with frozen embryo transfers.
So, for example, day 5 blastocysts would be ideal?
In my opinion, yes.
Okay, that's really informative information. Thank you very much. The last thing, I'm sorry, before you go, someone watching has said that they haven't had their period yet for 3 months. What would be your initial advice for that?
Well, try a pregnancy test.
Okay.
If it's negative, I would strongly suggest a scan initially, maybe coupled with some essential hormonal tests, which would include the standard FSH, LH, progesterone testing, maybe prolactin testing, and thyroid testing as a baseline.
Okay, great. I hope that's answered your question. Thank you, everyone, so much for joining us tonight. Really, really appreciate your time. Thank you so much, Dr. Elias.
You're very welcome.
I hope I said that correctly.
That's absolutely fine.
You don't have a good Greek accent.
You're getting there.
But yes, thank you very much. And
you're very welcome, Elias.
Good night.
Thank you so much. Thank you.
Bye-bye.
Good night. Thanks. Bye-bye.